So some folks might already be familiar. We've got a couple of current or former members in the room, but for those of you who are not, this will be a little primer for what FIMR is. FIMR is the Fetal and Infant Mortality Review. There will be lots of acronyms. If I forget to explain any of them, shoot that hand up, say, hey, what's that? And so it's on the screen there. This is a definition from an organization called the National Center, which supports fatality reviews nationwide. Sorry. It is a community-based, action-oriented process of reviewing cases of fetal and infant loss in order to improve those maternal and infant health outcomes. So I do like to try to put both in there, that fetal and infant. So we do think about stillbirths as well as the infant deaths, although, there's a different focus as we work through these. And then this image on the right over here is sort of just kind of the cycle of FIMR. You don't have to worry about the words. I'm gonna explain that. So the data gathering part on the top right there, that is primarily me at this point. That's the intake. That is the multiple sources I have for hearing about cases. I start investigating those cases. So I pull in additional supportive data. I bring in healthcare records, medical examiners. If I can get access to social services records, I try to find those as well. Christy mentioned our interview process. That's been on hold since COVID, but we are hiring to eventually bring those back. That will be an additional source of information there. So data, I always feel like, is maybe not quite the right word. It makes you think of numbers on a spreadsheet. This is extremely qualitative data. We obviously do put it into numbers in a spreadsheet to create our metrics that you'll see down the line, but it is pulling in a lot of information to create a story. That's what I do with it all. I de-identify it, take out names and specific dates, and then I put it into a narrative, a story of the pregnancy, the delivery, and if it's an infant loss, that baby's life and the incidents around their death. That goes to the case review, which is the green arrow down there. And so again, we have a couple members here. That is where I pass out those summaries. We read through them together, we talk about them together, and we talk about what were the points in time where something could have gone differently. Could there be a program? Could there be a resource? What supports are needed where this could have gone differently? And so FIMR has largely been on that right half right now. We're moving into this left half, so over into this pink one, community action. Thank you, Rosemaria. That's us. That's what we're starting here, because that case review team generates recommendations. So those points in time that they think, what can we do? I've got a docket of recommendations kind of ready for development and creation so that we can bring in the numerous relevant stakeholders. And then that final top left one is the goal to bring about systems change so that we can get that high level change and start turning the ship there. And so for FIMR in Milwaukee, it actually started in the 1990s. It was started and run by the person I directly took over from, Karen Mahalski. If any of you are familiar with her at all, she founded it, she led it. At various points in time, she had assistants, but it was really Karen M doing the FIMR work in Milwaukee. She had a social worker background. She was a strong mama bear for those FIMR families. And so it has been led by the Milwaukee Health Department. There has also been partnership with UWM for various purposes, but it has been housed in the health department, and we cover the majority of Milwaukee County. I say majority because there's some agreements around some of the other municipalities, but it is most of the county. So when I started in fall of 2022, there was, that desire to revitalize, to revamp, see what's going well, what needs to be changed. So by the winter, I had assistants facilitating a SWOT analysis with the case review team so that we could hear from them what's, those strengths, weaknesses, opportunities, threats, and, wanting to see action. That was really the predominant thing that came out of that. There were other good suggestions that I've used internally, but the desire for action was the big thing. We're also working on data management upgrades. That's an internal thing with me and my coworkers. And then we also adopted a charter with the case review team just to kind of give that little bit of formal membership, particularly for those folks who are very committed and show up nearly or every single meeting there. Was there one more point at the bottom there? That was it. Okay. Okay, so I kind of touched on that. This launch, that's part of the revitalization. So now I believe this one's yours, Christy.
All right. So Melissa kind of covered what the case review team is. So we have two acronyms here, the CRT and the CAT. The CRT is the case review team. So they cover all of the individual cases of fetal and infant death in the Milwaukee area. They're a multidisciplinary team. We have doctors, nurses, social workers, public health workers, researchers, health department staff. There's a lot of people on that team who have a lot of different specialties. And they go over case summaries to get the whole picture of that infant loss. So they're looking again at medical records. Once we get it up and running again, we're going to have parental interviews, any social service records that we have to create a whole picture of what happened throughout the pregnancy and then throughout that process of the infant loss. They also explore the what, the who, when, where, and why of those losses and try to identify points of intervention and prevention. So those are where those recommendations are coming from. They're looking at what could have happened to prevent this, and so what can we implement for the next child so that they can survive. The CAT, or the Community Action Team, that's us. So we, also a diverse group of stakeholders, are invested in improving those maternal and health outcomes by putting action. So we're taking those recommendations from the CRT, we're refining them, we're talking about what's feasible, what's practical, where to implement it, who should be the person who is leading that implementation, how is it going to be sustained, things of that nature. And then we're going to be putting them into action so that, again, we can see that needle moving and we're lowering infant and maternal mortality.
The jumpy laptop.
All right, so this is like a brief overview of what the responsibilities would be if you were to join our CAT team. So again, we're using those recommendations from the case review team, and we are identifying what is actionable. We want to, again, make sure it's feasible and practical, make sure that what we're implementing both in systems and in communities makes sense, that there are things that our community members want and can use and access. We are also making sure that we're building relationships with new agencies and also partnering with our own connections and organizations to put these actions into practice. We are collaborating as a team. We want to recognize the value of diversity when we're preparing for implementation. That's why we have people from all different walks here today. We have community members, we have people from industry, we have other review teams and medical staff and social workers. Like, it's a whole diverse team because you all have valuable lived experience and valuable professional experience, and we want to value that equally. So we are also wanting to make sure that we are creating an environment of psychological safety, allyship, and well-being. The topics that we're going to be talking about are very sensitive. Some of us do have lived experience, and it's a hard thing to talk about in general. And we just want to make sure that we are creating space for people to, have whatever feelings there are, feel safe to share their ideas, to share their concerns or criticisms of an idea, and make sure that we, realize that it's a space where we can be honest without placing blame. And then again, we're committing to participating in these collective efforts to make sustainable change to reduce infant mortality.
So before I go into the next section, are there any questions so far? So that's CRT, R is for review, those are cases, CAT, A is for action. This is a big scary table. If you want the details, we can go into those details. This is mostly just to show, because going forward, there will be some graphs that have comparisons with Milwaukee compared to a handful of other cities. And so this is just why those were chosen. This is all publicly available, so I can share data sources and everything like that. So looking at a combination of population size, regional geography, racial and ethnic demographics, and then things like, actual square area and density, and then the poverty rate just for that little bit of kind of social factors there. And so I came up with Milwaukee, Chicago, it's our larger Midwestern neighbor. Baltimore is actually surprisingly similar to Milwaukee in a handful of ways. Washington, D.C., Cleveland, and Memphis. So we've got a little bit of outside the Midwest, mostly inside the Midwest, just to see how, how we stack up against some other ones. This is a kind of messy graph. It's going to get cleaned up and published in the FIMR report that will be coming out later this year. I put some notes for myself because even I did not put notes for myself. That's fine. Everything's fine. So this is the city of Milwaukee. Our infant mortality rates. It says 3-year rolling average, just to give you guys a little data context. That's just a way of calculating the rates that smooth out the big jumps that can happen. If you do these solely year by year, there's enough variability that it just kind of goes up and down. It bounces around a lot and it can be hard to see if there's a trend happening. So we do 3-year rolling averages and it lets us see the trend lines a little bit. So the dark blue line, that's kind of through there's a cluster underneath, and then the dark blue line, thank you again, Rosemaria, that is the city overall. So you can see it's like sort of going down, but if you actually look closer at the numbers themselves, it's not changed a ton since like the mid-aughts a little bit. And then the gray line up at the top, that's what we're really looking at. That is our non-Hispanic Black population. And again, it's like, oh, it's going down. But if you look at the numbers, once again, it's not terribly unchanged from the mid-aughts in there. Again, it just kind of moves up and down. But if you look point to point, it's relatively flat. It gets a little messier in there. The orange line, the darker orange line, is our non-Hispanic white population. And that population has seen decreases in the infant mortality rate. So it has been going down, while again, that Black population is staying flat. So some groups are seeing improvements and some are not. The other lines, the yellow is Hispanic and the lighter blue is the Asian population. They've got a lot of variability. Working with my data team to see if we can dig into that a little bit more, but they're kind of bouncing around more so than the other ones. But as you can see, all of the other populations are still below that city overall average. And so
except for Native Americans, we weren't able to.
Native Americans are a little tricky. The raw numbers are small enough that it can be tough to get rates. It can be tough to report on, honestly, because it could be potentially identifying. If there's even one case that, if we plot it in the year, you might be able to know who that is. But yes, that is another population that's really significantly impacted by this issue. And then the green line there is our Black-white ratio. So that's the disparity that we're always talking about. And that's where we get that, Black babies are 3 times more likely to not make it to their first birthday kind of thing. And
most recent is 5 times, 5 times Black people are losing their babies to whites. That's what that is.
Yes. And so you can see it was largely flat, but it's going up. And again, that's a factor of the fact that the Black population, the rate is staying the same, but for whites, it's getting better. So that gap is getting bigger. And so that's why it popped up at the far end there. Yep. So it's not necessarily that things are worsening for our Black population. It's just not getting better fairly. So here we have infant mortality across those comparison cities. Milwaukee is the kind of middle blue line. I'm pretty sure the colors will be the same across all of the graphs that we're going to see here. So keep that middle blue tone in mind there. So we're kind of middle of the pack, maybe top end of the pack. Cleveland also has some work to do there. And, we can see some other, like Chicago and DC are doing something better. And this is the overall infant mortality rate. A lot of graphs are coming at you. I'm going to try to explain them. If you need anything further explained, let me know. And also, there's no quiz. You're not going to be tested on this information. This is just to give you guys context. So this one, it's 2 side by side. The scale is the same on the graphs from side to side across there. On the left, we have our non-Hispanic white population. On the left is that non-Hispanic Black population. So we can see that disparity is so significant that there's almost no overlap in how those populations stack up against each other. So it's not unique to Milwaukee. The scale here might be pretty notable comparison wise, but this is not just an us problem. Many places have to work on this. This is, again, a lot of information. You don't have to worry about reading the graphic there. I just took screenshots from our previous FIMR report and it was tough to cut out the text that accompanies it. This is showing the leading causes of infant death. So the big pink section there is complications of prematurity. The dark blue section is, today it would be called SUID, but it's those sudden and unexpected infant deaths. That includes your SIDS, that includes your sleep-related cases generally. And then the lighter blue one is congenital anomalies. So when you're looking at that, those first two are preventable. Congenital anomalies, it gets a little more questionable how much can be prevented in there. But for prematurity and those SUID, those sudden and unexpected losses, there's a lot we can do. The other smaller pieces are various combinations of infections, complications during the labor and delivery itself. And then depending on the year, very unfortunately, there might be a motor vehicle accident or even a homicide. So actually go back one more. So the words on the left here is just giving a little context because this is for overall. For the non-Hispanic Black population, prematurity is an even larger share of this. Congenital anomalies are less. For the non-Hispanic white population, the congenital anomalies were a full quarter, and then those sudden unexpected losses were a smaller share. And then for our Hispanic and Asian populations, both had much larger shares of congenital anomalies. And so for that prematurity can be prevented. We can get into it more a little bit later as well, but there's reason to believe that stress, just like general living with stress, can impact your likelihood of prematurity as just one factor. And then, the kind of care you get, things like that. So now you can go ahead forward. And this will be the same type of information for leading causes of stillbirths. So the big pink section is related to maternal risk factors. Again, this is from the report. These are all laid out in the report itself, which is available online. But this is kind of a mishmash. It's a bunch of things related to the mother, the pregnant person, and their pregnancy. We can see that light blue section, nearly a fifth is undetermined. Sometimes it's just hard to tell what happened during that pregnancy. And then we have a handful of pregnancy-related things. So like cord issues, placenta issues, abruption, or other things like that. And so similarly, the non-Hispanic Black is, their risk factors are generally like this graph displays. For the non-Hispanic white group, the risk factor and undetermined sections are actually the vast majority. They take up nearly 80% of the graph. And then all those other kind of physiological conditions, it's mostly just cord and placenta issues. It's a smaller share overall. And then for the Hispanic population, almost a third are considered undetermined.
So this is from the report, so it doesn't include the data that you're working on just yet.
Correct. This information is there's quite a delay. It's as of 2018, but generally the overall trends of these kind of numbers don't change terribly much from report to report. But yes, a fresh report will be coming out soon. So now we're getting into some data around the social determinants of health. So those kind of other factors outside of healthcare, socioeconomic, social context, things like that. So this one is percent of households receiving public assistance. Again, Milwaukee's that middle blue line, and we're second up there, around 28-30% of folks. And then this one I do need my notes because the grays are far too similar. Uninsured, Milwaukee County is the middle line here. So this is, yes. This is percent of adults who are uninsured, again, just to give that kind of access picture a little bit. So that middle one is Milwaukee County. The red one, which is lower, is Wisconsin. And then the upper one is United States. So surprisingly, we were kind of in between there, doing a little worse than the state, but a little better than the country overall. And then the shaded area is just the margin of error. This is the percent of adults who said that they delayed receiving medical care due to the cost. So again, Milwaukee County is that middle one. It's a little over 10% of folks reporting that they delayed care due to cost. This doesn't necessarily overlap with insured status perfectly, but there are two contexts around how our patients, how our community members are getting their health care.
This is general, not just maternal, correct?
These are overall population, yes, for Milwaukee County. And so this is those context pictures of percent of the population in poverty. Again, we're kind of number 2 in there, kind of at the upper threshold with 25-ish% of folks in our city are living in poverty. Housing costs are here. We might see some other housing ones, but for this graph, excessive housing costs is considered 35% of household income. Milwaukee's actually at the top for this one. As we can see, all of these graphs have kind of trended a little bit better and then flattened again in recent years.
Which is pretty high, because usually they look at 30% when it's above 30%, so.
This is just the particular data source.
Right. So
Yeah, that's about,
so might be underestimating.
yeah, it could be, that's like a third of households there. This is, looks like a lot, again, I'm gonna pull up my notes just to make sure I remember. This is to kind of give a broader picture, so the left-hand map is from the previous FIMR report, and that's infant mortality rates by zip code. So the green is good, yellow is medium, orange and red is getting worse, and those really dark reds are our most concerning zip codes there. The middle graph is Milwaukee GI equity, and so that's rent burden again, and this one is 30% of income, I believe. Oh, 25% of income. So the scale is just a little different than that previous graph, but it is still about rent burden. And then the one on the right is just a map showing zip codes by no health insurance status. So if you've heard the phrase, every map of Milwaukee is the same map, we can see those patterns coming up there, where those dark ones show up. So it's, we know the areas that have been historically disinvested, we know the areas that are struggling and need our support. So this is just a little bit of an expansion of that previous one. It brings in the specific zip code of 53206, which has some notoriety, of course. And so infant mortality it's seen as a measure of community health, not just of that one baby or that one mom or parent, that is community health. So the inequities that occur in singular zip codes, let alone Milwaukee as a whole, there's not just that alarming loss of life of those individual lives, but there are broader implications like we saw in those previous maps. Every map of Milwaukee is the same. These are systemic issues. And so this is just showing that, again, there's that racial disparity, but we can even get into zip codes and see an even greater disparity there. This is just kind of giving, it'll probably be easier. I should be able to send out these slides afterwards if you want to actually be able to read this a little bit better. This is kind of a logic model showing on the far left is sources of historical discrimination. They lead into these community level outcomes like residential segregation, concentrated poverty, degraded physical environments in your cities and neighborhoods, the wealth disparities that exist, even intergenerational trauma. These community outcomes keep going downstream and they hit those individual outcomes. So this one's kind of focused on housing here. Again, that rent burden, distressed neighborhoods, substandard housing, is your housing safe to be in? And then those feed right into our maternal health impacts. So it's these, we take these big historical things, they don't stop impacting our communities, and our communities are where our individuals are. So we got through the data part. You did it, guys. Any questions there? It was a lot. I was like trying to figure out I have even more graphs, but I'm like, what do they actually take this picture?
But one thing I think is notable is that we haven't been able to find a lot of information is overlaps that gets the social determinants of health that overlap with the maternal data. So that's why so many graphs too, because you have to kind of give a sense in general what the population is.
So equity, I mean, that's a popular, very hot topic term and word. You don't equity and equality, diversity and inclusion. But when it comes down to like looking at our community action team and thinking about equity, the equity means for us, like everybody has something to contribute to this team. Everybody brings something valuable to the table. The reason why we have a diverse, as Christy kind of mentioned, a diverse group of people in the space is because people are bringing insight and experiences. So to be able to bring that to this membership, saying that I have an input on this, but I also have an ability to be able to take something back and be able to implement change in our environment. So like how we actually take the data that Melissa so wonderfully gave us and there's what I kind of look at as like a translation. So like how she presented that to us, it translates into how we take it back into our work environments, how we take it back into our community. So being able to look at it from that perspective as well. So then we're looking at like our birth outcomes and our mortality rates, and we all understand that there's numbers, but the numbers translate into the work that we do, the communities that we serve, and the environments that we're in. So being able to look at that and bringing that all together and saying like, this is my part, and collectively bringing that all together, because we are a collaborative team and we allowing ourselves to put in that input about what our part is, what our experiences are, what our knowledge base is, and being able to bring all of that and put that into like one pot together. And then we can take all of that and turn that into an actionable item. So the big word about this team is action. Like, we're all here because we want to have something actionable. We want to be able to do something. We don't want to just take something and just say, well, this is what we thought of, and then we're done. But how do we take these things and return them back to our organizations, turn them back into our places of work? How do we turn them back into things that we actually do when we interact with people that are impacted by this on a day-to-day basis? And implementation. So of course, action takes implementation, but yet again, how do we take that work, those things that we have been presented and we shared and we talked about, those recommendations, and we translate them into how we turn this into something that will have an impact in either the places that we work, the organizations that we're part of, or the communities that we serve. And that diversity brings us to a different level of equity. So like I said, not just a hot topic term, but how we all bring value and insight into what we're actually doing. And that we're all, again, working together to be able to bring this impact and bringing the work into a different space, because lived experience, shared experience, community work, organizational work, all of us have some type of value and part that we're going to be able to bring to the table to make this something that we're all collectively proud of. And we all can say we had a part to contribute to this.
So if you are here today and you're like, oh, I don't have the capacity, or I can't, or this doesn't seem right. I mean, we are looking to have diverse voices on this, just for everything that, Chantel just said. And so those overlaps in that data, we're working in the same areas, no matter what area you're working on.
So no part of a team without a commitment, right? So what we are asking for, and probably no surprise to anybody, but like your time. Of course we need your time, because how else are we going to turn anything to action if we can't put any time and work into it? So we're looking at how we're actually going to consider, what are we going to do with that time? How often are we going to meet? When are we going to meet? Are we going to meet in different formats? Or I'm throwing like hands into the table right now about in-person formats, because it's something about being amazing of looking around in the space of everybody who's actually invested in making a change within our community. So just seeing like now when I get to see you next time, I get to be happy to see you next time, because you can, because so it's like, because then but we all know that we're all in and we're all invested. So that's just an amazing way to be able to do that. And kind of what we talked about with the equity, it's like having the expertise, because everybody has something. So be it if it's through a lived experience, be it if it's through you have on the innovation side of how your organization is bringing something into this community. And so you get to come back all excited to your organization and say, guess what I found out today? And this is something we can actually add and do. But just your enthusiasm for being present in that space, and then also being able to share the things that you're doing into this space, so that we all have some type of investment and understanding of what's going to happen and how we're bringing this into the space and work together that way. And as far as us being an effective team, I already got a good vibe. I think we are going to be an effective team. We're gonna go through this, but on this note, we're gonna talk about like, how can we be an effective team? Housekeeping rules. Let's listen effectively to each other, because everybody has something valuable and input to bring. No one has any more or any less. All of those inputs bring power and action behind the words that we're actually doing. And I love being tough on ideas and not members, because of how we bring our information into the space. We're all also in this space to be able to learn from one another as well. So it's not that we have one person who can just share all the information and all the experiences. Everybody has something. And then when that person is actually sharing, we're also listening to how can we do something to make something better for everybody else. And talking about tolerating the use of stereotypes or prejudicial judgments. I'm a big fan of taking things and saying, checking something at the door, but if that's something we can leave when we come into this space and allow it to first be about human beings before it's about anything else, then we can talk about what the barriers and things that we may have to adjust to be able to make improvement with other people. Then making sure that we receive something, but we can also give something. And then that's actually giving back feedback into listen. And the FIMR team, and it's as far as like suggestions about the process, because we're all learning and growing together. So being able to share, like, if we think of something that can actually improve what we're doing here, like, don't be afraid to share it, because you never know, somebody else might be sitting there thinking the same thing. So they might just be cheering you on in the background to be able to share that in our space.
And just because I looked ahead at the slides coming up a little bit, and I don't think we fully touched on it. So just to go a little bit more on the expertise part, not all the recommendations are healthcare related. So you might be like, well, you need doctors in the room. We do need doctors in the room. We're still working on that. But there's gonna be those social factor ones, social services, economic aspects, again, the social determinants of health, where they start getting bigger and bigger. And so we might be here talking about like, oh, all the hospitals are gonna commit to launching this great new program. And then you guys at Pathfinders are gonna say, well, hang on, my pregnant homeless patient, like, they can't get there. What are you gonna do for them? And so the more we bring in more folks here, that is the kind of stuff we want to make sure we're considering. That's that feasibility part. Who's actually being reached with the suggestions that were coming up in this room down the line when we get to that point? Because you all have your clients, you all have the populations that you work with and serve and what their needs are. And so make sure we're not leaving folks behind there. This is another slide that came out of the 2021 report, so it is available online. This is just your introduction to some recommendations that already exist. So the variety that recommendations can take. So we've got identify unmet social service needs and connecting patients and their families to those resources. Maybe that looks like a social determinants of health screening for patients, things like that. Advocating for policies that can improve overall social and economic health. So that's why we've got our policy person in here as well. And again, we're looking across the lifespan. So we're focused on pregnancy and infant loss prevention, but you have to consider the whole lifespan for a person to work on that. Another recommendation is support community-sponsored health navigators to improve patient engagement. Extending postpartum Medicaid eligibility, that is once again up at the state. Fingers crossed this time. They can get kind of specific. So for example, when pregnant people go to the emergency room, improving the knowledge of emergency healthcare providers around there, see if they can check if this is a multiple emergency visit. You know, there are very healthcare specific things in here as well. Health and reproductive life planning as an individual right. And then it can get specific again, like smoking cessation. How can we get resources to the folks who need that information the most? Alternative options of stress relief to help people navigate that. And then it comes up in a lot of spaces, improving partner engagement and recognition, particularly in the healthcare sector. Sometimes if you read a chart, you don't even know if that person is married. Are they with the father of the baby? Are they estranged? Who knows? So let's try to get that documented. And then in the broader picture, engage those partners more in the whole process. So again, this is a sampling, and as you can see, there's room for interpretation. How are we gonna involve those partners more? So that's where this team talks about how we implement, what specifics need to happen, who's gonna do it, all that kind of stuff.